Good afternoon, everyone present here. I am Faraz from IGCP Group. Welcome all the participants on today's live discussion on a very important topic, that is vaccinating the vulnerable strategies for adults with chronic illness on the occasion of World Immunization Week. And for this topic, we have very eminent speaker, none other than Dr. C.H. Asrani sir. And let me share some of the achievement of sir. Sir has done MBBS, DNB, Family Medicine, and founder and chairman of INCHES Group. So, by taking not much time, I would like to invite sir and hand over this session to sir. Sir, the stage is yours. You can proceed from here.
Thank you, Faraz. Welcome, participants, to have taken out time from the busy schedule. Who is the vulnerable patient population? They are individuals who are more susceptible to negative health outcomes due to various factors. It could be pre-existing disease, it could be malnutrition, it could be socioeconomic conditions. What we are dealing here is vulnerable patient population with regards to pre-existing diseases. Different patients fall in vulnerable group, infants, because they have a very poor body reserve. An infant can die with one large stool or less large vomit. Young children below 5 and older adults above 60 or maybe above 50 with multiple comorbidities. They are particularly vulnerable due to the developmental stage in the infant and child group and the potential for age-related health condition in the elderly group. Individuals with chronic conditions like diabetes, hypertension, dyslipidemia, pre-existing heart disease, pre-existing kidney disease, or mental health. Why mental health? Because then they cannot look after themselves as they ideally should. They require long-time medical management and they are at a higher risk of complications that these diseases bring. Their severe outcomes are higher risk as compared to others. A patient of 45 with a diabetes of 10 years is less likely to suffer a heart attack or a stroke or a diabetic foot than a patient of 65. Adults with conditions like diabetes, chronic kidney disease, cardiovascular disease, cardiomyopathy, old history of coronary artery disease, infarcts, chronic lung disease, COPD, asthma, bronchiectasis, known case of cancer, even though survivor for 5 years, still is a risk. Or those on immunosuppressive therapy for any autoimmune condition are at a higher risk of complications from preventable infections. Sorry. Infections that can be prevented. Everyone requires a vaccination plan which is tailor-made for them because it's not like pediatric age group that a common vaccination chart suffices. Here we have to prepare a vaccination plan depending on the patient's condition, ongoing treatment, chemotherapy, steroids, or whatever. Vaccination plays a very crucial role because that is a sure shot means of prevention in reducing morbidity and mortality among adults living with chronic health conditions. These individuals often have compromised immune response because of their pre-existing condition. Uncontrolled diabetes is the most common immunocompromised status, which may be as bad or worse than HIV/AIDS status. Patient on autoimmune disorders, patient on immune suppressant drugs, they're all have very poor immune response, and then timely immunization is likely to be a savior for them. It's a widely accepted belief that disease prevention is the most economic option to treat. In every field, prevention is better than cure, but when it comes to diseases which cost a bomb, it is better to spend some money preventing it. And many times, immunization has helped mankind to eliminate diseases like smallpox and polio. Now, we all in practice are using pediatric immunization to the hilt because it is accepted norm. Now, let's look at adult immunization or immunization of the vulnerable group. Somehow, till COVID, adult immunization was not taken very seriously. I have been giving influenza and pneumovac for last 15 years, but it was a big task to convince adults to take. Doctor, I am not a child. Why do I need vaccines? COVID opened everyone's eyes, and that said that a preventive strategy has a bigger impact on population health as well as individual health. It is wrongly assumed that adults are less susceptible to become a victim to traditional infectious agents. Actually, after the age of 40-45, the immunity starts dropping, and a 70-75-year-old may have immunity like a 5-year-old. Gradual lowering of host immunity has complicated the prevalent fragile health status. We all know that as a community, we are unhealthy. Even WHO, in addition to considering child immunization as a first priority, time and again keeps issuing list of essential vaccines for adults, as also CDC, Center of Disease Control, United States of America. For doctors who were already aware of this, it was an uphill task to convince patients. Patients should not feel that the vaccine is more for doctors' benefit and less for me. I'll give an example. Economic consideration during H1N1. Few years ago, we had an endemic of H1N1 in India, and I would tell my patients that one vaccine is costing you 1500 rupees. Four members of a family can take a vaccine for 6000 rupees. Whereas if I suspect H1N1 in one person out of four, then the swab test alone is 5500 rupees. But people still would fail to understand the economic consideration. That is why today I believe that IGCP has arranged this seminar. So let's take vaccines one by one. Influenza, annual dose, all chronic illnesses can be given from any age onwards, but for senior citizens or elderly people, any chronic illness they have, whatever you think of, influenza vaccine is indicated. Prioritize especially for COPD, bronchiectasis, asthma, heart failure, and diabetes. There are two types of influenza vaccines. The most commonly used and widely used is injectable. They are vaccines that protect against three or four. Now we have four tetra. Influvac tetra is the brand name. I'm not favoring any company, but four influenza viruses that research indicates are most common affecting the human body. These vaccines are given intramuscular or subcutaneous depending on the manufacturer. Types available are trivalent. Now it is tetravalent inactivated influenza vaccine, Influvac, Tetra, and quadrivalent inactivated influenza vaccine Fluatrix. In whom you should give? Ideally, although the talk today is vulnerable population, since we are practitioners, I am giving some little extra information for the practitioners. All people 6 months of age and older can be given annual basis, especially persons with chronic medical illness, immunocompromised individuals. They have a high risk of severe influenza, and severe influenza can kill. If you look at the statistics of America, influenza is a big killer there. All pregnant women, all people above 65 years of age should be vaccinated. You can start at 50 also if the person is health conscious. Single dose, half cc, intramuscular subcutaneous annually. Whom not to give? People having moderate to severe illness with fever, past history of Guillain-Barré syndrome following influenza vaccine, history of immediate hypersensitivity reaction to eggs. For people who consume eggs and get a severe allergy or anaphylaxis, allergy to any of the ingredients of formaldehyde, gentamicin sulfate, or sodium deoxycholate should not be given these vaccines. But this is theoretical. In practice, everybody can tolerate. Then there's a second vaccine called nasal spray. It is a live attenuated vaccine. The earlier one is a killed vaccine. This is a live attenuated, so it is more risky, especially if given in immunocompromised people. Ideally, healthy non-pregnant individuals aged 2 to 49 years, because in pregnancy you can't even give active virus, intranasally annually. Whom not to give? Age above 50 years or below 2 years. So please, if you are using the nasal vaccine, you are not to give in the vulnerable elderly population. In pregnancy, in immunosuppression, chronic medical conditions where the immunity is down, you have to avoid it. So basically, the message I want to give is give only injectable influenza vaccine, not nasal. Then we come to pneumococcal. There are two varieties, PCV, PPSV23, indicated for heart disease, lung disease, diabetes, CKD, chronic kidney disease, chronic liver disease. Sequence and timing may differ based on age and condition. I'll give you an example here, a case, a patient of mine admitted 3 times in 2 years with severe bilobar pneumonia. I had referred him to a pulmonologist. This is about 9 years back. And when he came to me and he says, Doctor, my insurance is over. So if I get another pneumonia, I will not be able to afford hospitalization. So I asked him that, have you taken influenza pneumonia vaccine? He says, no. I was aghast. He was under treatment of a pulmonologist. We gave him proper pneumonia vaccine. He died after 4 years, and in 4 years, not one episode of pneumonia, whether hospitalization required or not required. So, vaccines help prevent any types of disease caused by Streptococcus pneumoniae bacteria. There are two kinds of pneumonia vaccines: pneumococcal conjugate vaccine, PCV 13, 15, 20 are available, but 13 is used most commonly, and pneumococcal polysaccharide vaccine, PPSV 23. Now, generally, we see that in children, PCV is given, but if the adults today that we are treating have not been given PCV in childhood, now we have to give. I'll tell you the schedule. Pneumococcal vaccination recommended for everyone above age of 50. All adults age 65 or older who have earlier not received a vaccine, PCV, are given one dose of PCV 13. We give Prevenar in India, PCV 13. And after PCV 13, within 1 to 2 months, we give PPSV, that is called Pneumovac. So we have pneumococcal conjugate vaccine, PCV 13, once in lifetime, and after a month or two, Pneumovac or PPSV 23 once every 5 years. And believe me, I have taken it, I have given it, and then it really works. These are the brands available. GSK PCV we normally use of Pfizer Prevnar 13, and PPSV there is Pneumovax, Pneumo 23 Sanofi, and Pulmovax 23 Lupin, all generally the same cost. So again I'll repeat, Prevnar 13 once in lifetime if not given in childhood. Most of the patients of 55-60 will never have the childhood card. So I'll give Prevenar 1, and every 5 years after that, I'll give a Pneumovac or Pulmovax. Then hepatitis B and hepatitis A. Hepatitis B, CKD, diabetes, liver disease, and hepatitis A in chronic liver disease. Higher dose schedule may be needed in dialysis patient. So whatever hepatitis B dose we give to non-CKD, in CKD and CLD, we double the dose. Hepatitis B types available, recombinant DNA vaccine. All unvaccinated adult at risk of contracting HBV infection, or a CKD patient who's going to be on dialysis, even if it's given in childhood, we would give now. Healthy adults are given 1 ml, 20 microgram intramuscular at deltoid, 0, 1, and 4 to 6 months. So ideally we give 016, we can give 014, or we can give 026. At least 4 weeks between dose 1 and 2, and 8 weeks between 2 and 3. Based on patient's convenience and your availability, you can use the schedule. Wait a minute. There is. Okay. Hepatitis B, if the patient is being prepared for dialysis, then they are to be given 2 cc at a time and 4 doses, 0, 1, 2, and 6. And 2 months after the last dose, anti-HBs is to be tested to confirm that the immunity against hepatitis B has built up. If a patient is in a hurry, I may not follow 0, 1, and 6 pattern. Like if a person is marrying a hepatitis B positive wife, then he can take 0, 1, 2, and then 6. So at least in 2 months he is prepared. He has enough immunity to marry. Hepatitis A, safe and highly effective way to prevent hepatitis A, contagious liver infection. Why we want to prevent hepatitis A? Because if a patient already has chronic liver disease or cirrhosis, a coexisting hepatitis A infection can kill the patient, put him in acute liver failure. Vaccine is typically given as 2-shot series, second dose 6 months after the first dose. Sorry, this hepatitis B has come up. No, sorry, it's going back. I'm sorry. Then we have not very often used Tdap, tetanus, diphtheria, and pertussis. In India, we don't use, but most of the people, elderly people, when they're traveling to US or Europe or even Australia, are advised Tdap vaccine, because there some countries, some states, diphtheria and pertussis have come up again. So Tdap vaccine is to be given single dose if not properly earlier received and may be repeated in 10 years. What is the difference between Tdap vaccine and triple antigen? Tdap vaccine has pertussis inactivated toxoid, whereas triple antigen had pertussis live attenuated. That's why it could not be given after the age of 5 years. Herpes zoster or shingles. I'm sorry, there's little confusion in slides. This I told you, Tdap vaccine has toxoid of all three. Old triple antigen, it was not toxoid. Shingles vaccine is the only way to protect ourselves from painful disease. Vaccination is over 90% effective in preventing shingles or herpes zoster and even post-herpetic neuralgia. If anyone in your family has suffered with post-herpetic neuralgia, you'll understand that it's a real torture to suffer from that because the medicines, if they work, take very long to get better. Adults 50 years or older, two doses separated by 2 to 6 months. And since we are talking of this now, if you have adults 19 years and older who have conditions which are reduced their immunity, then you may consider giving the same dose. If patient needs a early response, you can give second dose early also. But who are the patients? HIV, AIDS, cancers. In young patients, immunocompromised, you may consider giving herpes vaccine. Thanks. That's all for today. I am open for
Thank you
questions.
so much, sir, for taking out your important time and sharing your knowledge on this topic. I definitely think this session knowledge is going to help all the participants on their practice too. So we have received some questions. With all your permission, shall we take these questions one by one?
Yeah, please.
The first question I can see, sir, from Dr. Subramaniam. He is asking, how do you prioritize which vaccine to recommend for patient with multiple chronic condition, especially when immune responses might vary?
See, what I will definitely give is annual influenza and Prevenar 1 and Pneumovac every 5 years. These two are a must. I can, avoid shingles. I can avoid Tdap. I can avoid hepatitis B if the patient is not CKD and trying to go under dialysis. But these two I will make priority, influenza as well as pneumonia.
Thank you so much, sir, for answering this question. We have another question from Dr. Abhinav. He's asking what strategies have been effective in your practice to overcome vaccine hesitancy in chronically ill adults who are concerned about side effects of interactions.
See, I being a super senior citizen, my telling them that I have taken convinces most people. And I have another step which I don't know whether many of you may be willing to do or not. If the patient feels that it's for my benefit, in my clinic, I charge MRP of the vaccine plus 200 rupees pricking charges. So they also understand it is required. Then younger doctors can say, I have even given to my parents. That will make them understand. Then, wherever the cost is a concern, you can tell them one hospitalization of pneumonia will cost you anything between 3 to 5 lakhs if the patient survives, and preventing it is easier. And people today, I think after COVID, no, have started accepting adult vaccines.
Thank you so much, sir, for responding to this question with your expertise, sir. One last question I can see from Dr. Das. He's asking, have you seen any recent data supporting the use of newer adjuvant or high dose vaccine in older adults with chronic illness like diabetes or heart disease?
Which vaccine higher dose?
Sir, he has a newer adjuvant vaccine, sir, or higher dose vaccine.
No, I have not seen any data.
Okay, sir. Thank you so much for responding, sir. One feedback from Dr. Subramaniam. He has written, thanks for this case presentation. It was really nice webinar.
Thank you, Dr. Subramaniam, and all participants.
Yes, sir. As there is no more questions, sir, with all your permission, shall we conclude this session for today?
Thank you, sir. Thank you very much.
Welcome, sir. And we would like to see
Bye.
you in future also with different topics, sir. Till then, take care of
Thank you.
yourself.
Thank you very much. Thank you very much. Bye.
Welcome.